Lisa, can I just double check? Is this being recorded?
It is.
Hello,
Victoria's going to record for us.
Yes, the meeting. Yeah, the meeting is started and it's being recorded.
Amazing. I don't want anyone to miss out. All right. Hello to everybody who is just joining us. Appreciate that we are on the hour. So we'll just give people a few more minutes to join us and then we will get cracking. We'll just take one more minute to get everybody settled in and then we will start. Awesome. I think we are ready to go. Hello everybody and welcome to today's webinar hosted by FITFILE and in partnership with AnalystX and Population Health Data and Analytics Centre of Excellence. My name is Jessica Smith. I am delighted to be your moderator for the duration of this session. I'm co-founder and CXO of SOMEX, a health tech specific communications agency. For those of you who don't know, and I'm sure many of you do, FITFILE is a company working very hard to unlock the power of safer, faster, better health data for everyone right across the healthcare ecosystem. And today we're going to be talking about bridging silos in health data and how a London trust has changed the way that it thinks about health data to really transform the way that it's delivering care for people living with long-term conditions. So I am therefore delighted to introduce our panel. First up, consultant gastroenterologist from St George's University Hospitals NHS Foundation Trust, Dr Kamal Patel. So would you like to tell us a little bit about who you are and what you do? Over to you.
Thank you to everyone who has joined us this morning and taking the time out. I am one of the consultant gastroenterologists at St George's Hospital. I have numerous interests and I am co-lead for the inflammatory bowel disease service at St George's Hospital. I lead on the service development for the service. I also lead on the research we deliver for the service. And you know, at the moment, one of the key challenges we have is how we deliver an effective service with the constraints which the whole country is facing at the moment. So anyway, that's who I am. I do all aspects of gastroenterology, but today we're specifically talking about the two bits where I have a leadership role in the hospital.
Fantastic, and thank you so much for joining us today and sharing your experiences. So over to FITFILE's very own Gurpreet and Petros. Please introduce yourselves. Gurpreet, over to you.
Hi, Jessica. Thanks so much for the introductions. So I'm Dr. Gurpreet Singh. I'm the Chief Health Sciences Officer at FITFILE. I've been a former GP partner for about a decade and a healthcare commissioner. And I was chair and chief exec of a GP federation that I founded and led for almost about 5 years. And I've been on the advisory board at Digital Health London Accelerator for a number of years as well. I am a practicing physician and oversee all things medical and health science related at FITFILE.
Petros, over to you.
Good morning, everyone. My name is Petros Kotsiris, and I am the Chief Data Officer at FITFILE. I've been in and around healthcare for most of my life, doing data before data became fashionable. And at FITFILE, I look after anything from our data engineering, our compliance, all the way to our analytics and machine learning efforts. Lovely to be here with you.
Awesome. I love that. Data before data became fashionable. I think we can all agree we're probably in there with you. Awesome. Okay, so one quick housekeeping thing for everyone who has joined us. We want this to be really conversational. Obviously, we're going to be hearing from Gurpreet, Petros and Kamal. But if you do have questions, please do pop them in the chat. If there's anything pertinent to what we're discussing at that particular moment in time, we may well come to you and answer that question there and then. But if not, there is time at the end for us to answer some of those questions, and we'll go through what's in the chat. And then if anyone has anything else to ask, just please raise your hand virtually. So we can't see all your faces, unfortunately, but if you could raise your hand virtually, we will come to you. So I will be keeping an eye on the time to make sure that you do have that opportunity. Yeah, awesome. Well, let's get into it. So we are here today to talk about the work that you, Kamal, are doing with people who are affected by IBD. So I would love for you to start by just telling us a bit about the project, where it came from and what it is that you're doing.
Fantastic. Okay, so firstly, I'll just say one line on IBD. IBD stands for inflammatory bowel disease, and the two most common in UK are Crohn's disease and ulcerative colitis. So we will be looking at patients with one of those two conditions today when we show our data. Now, you know, March 2020, I still have nightmares, but overnight, our nation changed and the way we deliver health changed. And, you know, as the pandemic was going on, we lost oversight of what was going on with patients with chronic conditions because we had another new disease which was taking up 70 to 80% of our in-hospital resources, which is the reality of where we were. And you know, I had to ask myself now to keep an IBD service going long term, and this is a chronic condition where 98% of our patients still meet their average life expectancy. So, you know, these are young patients who are going to have a whole life. How do we reintegrate that service back into the new nation we were finding ourselves in? And there were four things from my point of view, which were the top priorities. And these are obviously my personal opinions. One is equality to access. We want to make sure that every patient with a chronic condition is still able to access our service. The second question is the safety of the treatments we are delivering. Because, you know, these conditions need immune suppressing drugs. That's the nature of the condition, but they need safety analysis. And in a pandemic, it's very easy to lose oversight of the safety aspects of delivering a medication because it may not become a top priority because of the situation you are under. So safety was the second question. These are expensive drugs. We are looking at our two most expensive drugs. Obviously, they are NICE approved, so we are allowed to prescribe these, but there is a massive impact on our budget. Okay, so I also had this thing of, are we within the budget we have? Are we delivering this effectively, trying to protect the hospital? Equally, we want every patient to still have access to these drugs. So cost was another factor which we wanted to look at. And then the fourth thing is research. You know, I took a job at a teaching hospital from a personal perspective as well. And I do have some research time in my job. And, you know, when everything around you is under so much pressure, which you feel, research is sort of my pressure release, because we like to deliver research where we see an immediate impact within 3 to 5 years in our service. And, you know, those are the four questions I had in this project. What was really nice about this project is we were looking at London patients, so local patients to us where I'm working, not just at one hospital, at two hospitals. We're only showing data from one hospital today, but this was a cross-site project. And the reality is some of these questions which I asked, I have been asking my department for 2-3 years and was just unable to get these answers. So data, you know, as Petros kindly alluded to, is all over the place. The sad reality is that it is all there, but it is distributed across so many systems in the NHS, because that's how the NHS has been developed. So we have one system which is our patient reporting system where we write our notes. We have another system where all of the data for the high cost drugs gets inputted. They don't talk to each other. Then we have another system totally outside the hospital where, of course, patients will go to their GPs for additional help, and we have no access to what has happened in a GP consult. And the other reality is hospitals can't communicate with each other as well. So we have no idea what happens to a patient if they have an emergency visit at another hospital. In terms of, the finer details, you'll get a 3-4 line letter to say this happened, but we don't have the sort of, the intimate details we need to fully understand what is going through a patient's journey. So this is where the company came in. I went to university with GUPS, so I was aware he was working with this company, and we just had a conversation. And they have technology which can unite this data, which really the NHS admin sources we have don't have this capability to do this, and they don't even have the time, if I'm going to be honest. So we wanted to look at this population of patients to see, are we looking at their health management in a holistic view? Are we addressing drug access questions, safety questions, equality questions? And really, the pandemic had changed a lot of it. So it was a good time to look at it. And the pandemic has also changed how in future we deliver our health. So it was an ideal time to look at this. So that was the project as I had envisioned it from my eyes. I'll hand over now. Yeah.
Perfect. And I think what you described there, that experience of data being distributed across so many different systems, I think really echoes what we hear so often whenever we talk about data, particularly in the NHS, but in healthcare specifically, of so many other people, and the frustrations of many clinicians and people working in the NHS and health systems worldwide. So I think, it keeps coming up, and there's not been an obvious solution for a really long time. So it's really refreshing to be able to have this conversation and talk about actually some of the hurdles to potentially overcome that and actually make a real difference. So with that said, Gurpreet, I'd love to hear from you about the partnership from your perspective, and the work that kind of FITFILE has been doing to unite data. And what do we mean by uniting data? We talk about interoperability a lot. We talk about data access a lot, but what does that mean in practice, particularly in the context of what this project looked like?
Sure, Jessica. From FITFILE perspective, we've been really focused on building out our partnership base with high caliber institutions of care, and really looking to treat really important conditions such as IBD, right? So chronic and other chronic and long-term diseases. We all know IBD, as Kamal outlined, the impact it has on people, and it's huge numbers actually affected in the UK. About 500,000 people are expected to have diagnosed and or undiagnosed IBD in the UK, and particularly affecting that younger demographic group. And there's a serious impact actually on the impact on healthcare resources and on productivity. A recent BMC study showed about 27% decrease of productivity at work for IBD sufferers. It really impacts the quality of life. So really having really good control of disease is really important. And also it's a very important area for research for life sciences, with more than 40 real world evidence studies and registries currently underway. So we had the opportunity to link in with the renowned KOL, Dr Kamal Patel, who's the IBD lead at St George's, and we really jumped at that opportunity when we found he had a need for our technology, and really looked to kickstart this multi-centre initiative, which we expect to span data across other parts of London as well, the UK, and then ultimately we'll take this on towards Europe as well. Now, some of the the data unification pieces, I think Petros is going to come and talk a little bit about, I think, some of the specifics around that. But, to build on what we're really hoping to sort of achieve here, it is all about, serving the interests of population health management and making sure we have a good overview of that, linked to that, addressing utilization inequalities that Kamal mentioned, and really wanting to act on better understanding of biologics and the outcomes. And we've looked to bring together data from a range of sources that Petros will highlight in a moment.
Fantastic. So when we talk about, I guess, implementing new technologies and new initiatives within organisations like the NHS, health systems like the NHS, which we know are highly complex in their nature, and we've already talked about the fact that, you know, disparate and legacy IT systems. Clearly, data is a source of huge opportunity, but also huge frustration as well. So, Kamal, in this project, you know, I appreciate it's not always easy to get these things off the ground. So I'd love to hear from you a bit more about some of those challenges that you faced, I guess, as a clinician working in the depths of COVID, and also now in the new normal, I suppose, in which we find ourselves post-COVID, in getting this project rolling. And as you know, you've progressed through it, what have you found to be some of those tough things that you needed to overcome?
Yeah, I mean, you know, it's very interesting how the NHS works. So when you're a lead, and I always joke, my life was much better in a junior role, although everyone thinks you earn more money. But when you're in a junior role, you can just be a doctor. When you become a lead, you just have a whole, the patients are there, and you know that it will always remain my priority. But there are just problems in the service which appear on your desk, and you're told to resolve them. Okay, so it sums up nicely to, we have to deliver a lot more in the NHS at this time point with less money, you know, with the aging population and all of these conditions, because people are living longer, their compound incidence and their compound prevalence, is increasing. And because we are keeping these people well, the genetic predispositions with their genetic pool in society is increasing. Now, look, those are all good things, but we have to be able to adequately look after them. And if you can treat somebody properly, all of the complications which Gerb said, you can reverse. So you can almost give someone a normal quality of life if we can treat them properly. But the problem is without data, I can analyze data very well. I mean, we'll look at our slides. It does not take me long to analyze data, but I can't capture that data. And it's also not a good use of resources for any clinician, whether that's a doctor or a nurse or any of our allied clinicians who work in the hospital, to at this time point not be patient facing. You know, we need to use our time patient facing. And then of course we have to do the other aspects, but we need to do those other aspects as efficiently as possible in the time we have. Now, some of the data we're going to show you, I asked my department for 4 years ago, and they haven't been able to provide it to me. You know, there's one simple slide which I'll show you just in terms of how we get reimbursed from our CCGs. But the real issue is time to extract the data. And also we have to be fair. You know, I'm a clinician. I don't know how one system talks to the other. I don't understand, you know, what you have to link on to get one software to talk to another and how we extract that data. And equally, I'll also argue, I haven't done 16 years of higher training to become a consultant in my field for that to then be my role. Okay, so, you know, those are the challenges. We do need now teams in the hospital to provide us the data so we can future-proof the service. Okay, and we can redesign it for the needs. And, you know, I also worry that the needs are going to change consistently now, because that's the place we are in the world at the moment.
Great. And then Petros, over on the, I guess, more technical side, and also as a provider, we know that actually providing support and services to the NHS can also be challenging in and of itself. So I would be interested to hear from your perspective about some of those challenges, and then also, you know, what process you went through to get things going, and how you overcame those challenges too.
Yeah. I mean, in summary, Jessica, we've got the technology and contracting parts were very straightforward. We've got a well-honed method for this. Now, we've done this a number of times, and every hospital has got different processes, but we've got knowledge, experience, expertise, and it allows us to navigate different environments efficiently. Now, on the clinical side, Kamal and his team were excellent, and we got great support from the St. George's tech and data people. The biggest challenge always has been governance, and we absolutely love it. And there's a reason why it's a challenge, because we need to focus on privacy and protective privacy. This is paramount. Now, if I may go into a little bit more detail, we've got a method called the FITFILE Navigator, which is our project Bible. Now, it's a proprietary process map, which we continuously refine and improve with all of the projects that we do. We follow the learning out of each project, and it goes into the Navigator. And it gives us a clear timeline which we establish up front, key steps, major gating items, along with an agreed approach on how to deal with issues as they come along. We also seek upfront buy-in, of course, with key senior stakeholders, and Kamal was instrumental in helping us in that process. Now, both the navigator and the early onboarding of stakeholders allowed us to navigate the governance, sign the DPIA, take care of it as efficiently as possible. Now, the tech deployment dovetailed around the governance process. It's processes that work in parallel, of course. And engaging the stakeholders also allowed us to go through TDA, which is the technical design authority. The trust takes all of the technology decisions. And then the data discovery part, very collaborative element of our approach with trust personnel to protect privacy, to protect confidentiality, and also understand the nature of the underlying data. There's lots of times that you expect certain data to look one way and they don't look one way, they look a different way. So you have to understand why and where it comes from. But most importantly, I think we're able to use the unique unification technology we bring to get data sources from different places together in an anonymized fashion, which we believe is a safer and less complex way than pseudonymization or tokenization. And of course, the end result is that anyone can look at an anonymized output without privacy of underlying patients being exposed.
Fantastic. So Kamal, obviously, there will be some, I'm sure, many clinicians on this call and also people working inside of the NHS wondering practically, I guess, the process that you went through to get this off the ground. And I'm keen to also hear, how you overcame some of those challenges that you just talked about, but also how the partnership set you up for success, I think. And so perhaps what other clinicians and people working within the NHS can and should be asking of healthcare providers to make sure that these initiatives are successful and you're getting the right support. And I guess off the back of that, I think it would be a good time to have a look at the actual scope of the project as well. So over to you.
Okay, so fantastic. So a lot of questions there, so I'll make sure I answer all of them. In terms of my time impact has been minimal because we were meeting maximum twice a month for 1 hour on a Wednesday, which the team kindly did on a day where I have less clinical commitments. And the twice a month is the maximum we have met, if I'm going to be honest. A lot of months it was one, and a lot of months they were collecting data and would say, we don't even need to meet this month. But the most important thing obviously is to design the project properly up front, because you want to know what questions you're asking. Now, inevitably, you'll see data and more questions will come. So you will remodify it, but whatever an individual service needs, ask that question first. Okay, and have a project outlay. And we spent, I think, a good 4 to 6 weeks just making sure our project document was correct. Thereafter, obviously, as Petros mentioned, information governance is crucial. You can't have data breaches of confidential patient details, and there has been no risk of that in this project, but we had to go through the process to go through the IG, the Call to God Guardian. In a pandemic, that was difficult because people's times were limited. All of the governance leads and Call to God leads, and this needs senior sign-off, they're clinicians themselves. But it did mean communication by email, a few phone calls on my part to the leads to say, look, this is the reason we're doing this project. When you get a time, assist us with the sign-off. And that probably took the longest bit of this project, just getting the internal safety and governance processes signed off. Now, I will say to all of the clinicians out there, obviously that's mandatory, and we also have to protect ourselves. We can't do a project without the trust approval. So that whatever time that takes, it takes that time, and people just have to understand that genuinely everyone is working as quick as they can in those departments. After then, once we had the sign-offs, it's been pretty smooth sailing, because the communication between Petros and our IT team seems to have been, for my part, pretty smooth, because the timelines we've had for project outcomes we have met. Yeah, okay. In terms of talking about the project itself, I'll do that when we go on to our slides. because it will make more sense. So if we go on to the first slide, I'm not going to go through every individual parameter, but just looking at the left-hand side, we're looking at the 194 patients who are our most expensive drugs. So the cost of that, the drug expenditure there alone is over 3 million, just to put this in context. That's not the cost of looking after them. That's one aspect, just the cost of the drug. Now, the male-female split you can see is roughly the same, which you would expect. We've looked at this over 36 months, so it's everyone who got at least one dose of either drug. And what you see there is the age split. And as you would expect, it is mainly young patients. But this is something which the NHS is still not appreciating. You can see we have 85 to 90-year-olds on these medications. And it is very different looking after an 85-year-old on a chemotherapy type drug for a benign condition than it is looking after a 20-year-old from a safety aspect. Okay, and our model does not factor in for, you see how many patients there are over 70 years old, because they have a completely different care need of getting these medications than younger patients. So this is the first time I will be able to go to my care group and to our CCG to say, look, this is now not, this is not a condition of young people, which people thought this historically is. Because those young people are now living into their elderly life, we need adjustments in how we deliver this for that specific cohort, where it's not as easy to say, can you inject yourself this drug at home every 2 weeks? It's not as easy to say to them, can you remember to have your safety blood checks every 3 months? That group needs a different pathway to a younger population. Now, looking on slide B, okay, sorry, on the second side, on the right-hand side, there was a question of safety, and I was really worried. So biologic A, you get at home. Biologic B, you have to come to hospital. So the reason there's more people on biologic A is during the pandemic, we had to be more ambulatory. But I was worried that they weren't getting as frequent blood tests as they should be, because that oversight we had lost. And actually, what was quite nice to see is actually we used the CRP as a surrogate marker to see how many blood tests they were getting. And it is almost the same. The home group got one less blood test, which I can live with in a pandemic. That's not a real compromise of safety. So that was very actually reassuring data, because I was worried. We had just lost oversight. We were delivering them the drugs because we didn't want them to come to hospital, obviously, for a disease flare, but we had forgotten the safety aspects. So that was very reassuring. And, we now do have to future-proof our services for future pandemics. And at least I can take some reassurance that our home monitoring was still working. Petros, we can go on to the next slide. Now, this is really interesting data. Now, I'm obviously very passionate about IBD, and I would like to treat everyone who I can. Okay, but the reality is that the way the health service in England is designed is we are on block commissioning, and St. George's for IBD is not a tertiary service. We are commissioned at a secondary level. Okay, as I said, the drug expenditure alone is 3.5 million for these patients. And what you're seeing on this slide is that more than 500,000 of our expenditure is on patients who are not within our catchment postcodes. So we have aligned this with our catchment postcodes, properly, and we have looked at this. And very interestingly, we are treating patients who are actually living as far as Manchester and even further north in our service. Now, there is no way a clinician can know this. When I'm looking at a patient's notes, I do not look at their address, and I don't have time to look at their address. And equally, I'm not going to get into a confrontational conversation to say, I need to discharge you. You've been here for 5 years. But we need a plan for this, because this is, as I said, the hospital needs to save 50 million in the next financial year. We've already been told that. In theory, 1% of that saving is just in the drug budget here, because we don't get reimbursed at the moment on our block for treating patients out of area. We don't even get reimbursed for their other care. The drug is one aspect of it. So this data I now need to take to our care group lead, to our managers, and to the CCG to say, what do you want us to do with this? Okay, I'm not saying I don't want to treat these patients, but if they want us to continue to act as a tertiary service, then we need to be commissioned as a tertiary service, which would be the most reasonable outcome. But if we can't have that finance source coming in, then we're underserving our local population. And, it's a very difficult conversation to have. And I don't know if there is a right answer, but if they funded us, then we can serve them. If they don't fund us, we will have to start writing to these patients to say, please start making arrangements to have your care transferred locally. The waiting list for my next clinic appointment for a new diagnosis is 7 months at the moment. So, that's the challenge which I have. Exactly. That's the challenge which I have. Yep. And the money is now, it's almost arbitrary when a clinician's listening to it, because when a trust is told we need to say 50 million, you don't even know where to start. But, there is a solution here that either we bring in more if the commissioners accept that we are now being utilized as a tertiary service, or we have to discharge these patients to their local services, which is the national agreement. So, this data I've been asking for 4 years, because we had an audit of our service before the pandemic, and the finances we have caters for the resources you need for 1/3 of our local population. So we estimate we have between 8,000 and 9,000 local patients with IBD, and there are metrics which say for that many patients you should have X amount of doctors, X amount of nurses, X amount of pharmacists, and we are at 1/3 of that because of the constraints on our budget, and that's pre-pandemic. So
Kamal, it might be a helpful reflection that for everyone to know that the clinic has about over 1,000 patients, and we've only looked at just under 200. So this represents 20% of the clinic. There's still 80% of the clinic that we haven't done work on and haven't understood what the service funding challenge is there, and the number of potential unfunded treatment costs that exist for the 80% of the clinic. So the number could be significantly much more and be very meaningful for the trust.
No, of course. And the reason we looked at these 20% is these drugs are the most expensive. The other 80% of drugs, just to put it in value, are under 15% of these two drugs cost. But yeah, absolutely. This is a small cohort. This is not the entire cohort. And even when Gub says 1,000 patients, those are the 1,000 on the high cost drugs. We have at least another 6,000 who are not on low cost drugs. Okay, we can go on to the next slide. Oh, sorry, Jessica.
I was just going to say, I think what this articulates beautifully for me anyway is that having a much clearer picture of the data presents you and people who are designing services with a new insights that you have not seen before, where you were talking earlier about, I suppose, the preconception that IBD is a condition predominantly affecting young people, but actually what you've seen is that actually there's a much older patient population there, and actually from that what that enables you to do is make data-driven decisions about service design and service delivery to make sure that you're focusing care where it's needed most, and actually also addressing those two huge challenges which we know are so pressing in the NHS, which is time and money. And so ultimately it is a really good example of where everyone wins when actually you just have a better view of the data. And I think you're going to come on to talk about this now, but I know you mentioned some of the key highlights, and you've just discussed a little bit about kind of population health management, but also how you're utilising resources and addressing health inequalities, as well as understanding some of those, the biologics and the outcomes, which again, you've talked about differences in some of those drugs. So let's go on to chat about some of those a bit more, because I think I'm really interested to hear those high points and those, I guess, the results that you've got really excited about.
Okay, so just again, starting on the left here. So we looked at these 200 patients who are on actually the best drugs we have for the condition, if I'm going to be honest. And at the bottom, you have the national average of A&E attendance per patient, which is 0.29. And then for these patients, you can see that the IBD related attendances are twice the expected, but actually non-IBD related attendances are more than 3 times expected. Now, the problem with IBD is that the non-specialist is uncomfortable treating it, which is understandable. But we only have an IBD service 9 to 5. A&E will struggle to manage these patients. I appreciate that, because they don't have the higher training to deal with it. And there is a knock-on effect that if you have one chronic condition, even a problem which is not necessarily related to that condition or the drug you're giving for that condition is more difficult to manage, because I'll give a simple example. If somebody's on an immunosuppressant drug and they come in with something as simple as a bee sting, which is infected, because they're on an immunosuppressant, the management of that infection is very different to somebody who is not on an immunosuppressant. So we've never had local data like this to see how often these patients go to A&E, but you can see there is a massive utilization of these patients to A&E, and there is no A&E at the moment which is coping in England. Yeah, and anyway, but that's not a talk for today, but I'm going to leave that statement at that. But you know what this data on the left beautifully shows to me is at least we need one, again, funded hot clinic a week. So if we had a hot clinic every Friday morning and the GPs could tell the patients that, look, this is outside my remit, but I'm booking you into the hot clinic on Friday morning. If you have to go to A&E up to then, fine, you have to. You can't compromise safety. But if you can hold out till Friday, then you see the specialist. Okay. And then we have methods of integrating that hot clinic with other specialists anyway, because numerous hot clinics are running. We don't have one for IBD at St. George's. But so even if it's not necessarily directly an IBD problem, you have the relevant person in the hot clinic area to say, by the way, this is what I'm doing for this problem. For A&E as well, if it's just a matter of A&E doing blood safety checks just to see, can they then transfer them to the hot clinic? That's a much better model. And the patient will get a much better actually outcome for their condition, seeing a specialist. So this is, again, data for me to take to the hospital, to take to the commissioners to say, will you commission one hot clinic a week, which would be a good starting point. The graph on the right, obviously, is a massive topic at the moment where there are ethnic minorities which we feel are being underserved. Now, this is the first time we have looked at this data in our local population. So I also do the pediatric clinic for IBD at St. George's. And there is a massive explosion of IBD in the pediatric population and ethnic presentations we're getting, which we haven't been able to answer. But to put it in context, 1 in 2 patients I see in the pediatric clinic at the moment are of an ethnic background. Okay. Now, what we're seeing here is just looking at our catchment population, and there's no reason why, there's nothing in the data which says the Black community have less IBD than other communities. We would expect the same number to be on the drugs. And you can see here, there is a difference. And locally now, we need to do some follow-up work to this, because it's understanding why they're not getting access to the drug. Now, obviously, we treat everyone equally. I cannot foresee why that wouldn't be the case in our service. Yep, and it would. So I can't explain why this discrepancy is there. I think it's because the access is the problem to the service, and this is what we need to look at. And already as a surrogate second piece of work to this with the company, we're going to look at all of our patients who have had surgery, because one easy way of validating this data for me would be, if there is an excess population of this community having operations, then we are missing the window to treat them before they need an operation. So that's already a follow-up piece of work which I have in mind from this. Obviously, this is a massive issue at the moment nationally, even outside the NHS. And I hope in my lifetime, the equality of access is no longer a problem because of perceptions that people feel they can't come to us. So we will be going to community leaders. We will be going to the community to say, look, please do not stay at home if you're feeling unwell. There is no reason for you not to come. And the follow-up work from this is going to have to ask some hard questions to try to actually tackle what the problem is here. Yeah. We've already got in mind a research fellow to take this piece of work on now, to look at the aspects of the service not in this cohort, and you just look at where is the access problem here. Yeah. To answer this,
I think Kamal, you raised some really interesting points actually that really resonate with us when we saw this data about the utilization of unscheduled care services and about the access issue. Perhaps we should also think about talking a little bit about the next slide and maybe some of the outputs from that, and then circle back. I'm sure everyone's really keen to hear about what data sources were used and how that was put together and what the process is around that. Petros, could we have the next slide? So I think this is really interesting actually here, where we think about an insight that we gathered was that patients with higher BMI appear to be more unwell with higher CRPs on average. And that's really interesting. The CRPs, for example, average CRP for someone on biologic A was 46.5 and for biologic B was 34.4. Now, we know obesity is suggested now, and there's more understanding really that it's pro-inflammatory. And this initial analysis validates this. Further research is going to be done that will dig into what can be done to reinforce biologics with maybe patient support programs that can manage the condition as a whole and think of a holistic approach as well, because certainly we don't want certain patient groups coming in with a higher level of disease, and that's really important. we manage that. And perhaps it'd be interesting, Petros, to sort of give everyone a sense of the data sources that we use and process in place.
Yeah. So what we've done is we've targeted around 50 data elements that were of high interest. Now, apart from combining different clinical sources, prescriptions and EPR, pushing into primary care data, we've also integrated the healthcare side with sociodemographic data on aspects like ethnicity. We've used geospatial data when we're talking about postcodes to understand catchment areas of primary care, for example, as well as different benchmark data on hospital A&E admissions and what that means for IBD on non-IBD regions. And the work generally on what we do in here too includes identifying the data acquisition, of course. There's a little bit of wrangling to be done, always is, processing and finally presenting the data results into something visual that leads to actionable insight. Otherwise, there's no point in doing all of this.
Awesome. I've noticed a couple of questions, and I think it might be an opportune time to answer them. So, Petros, I think the first one is for you, and that's about how you consolidate the data across different sources for the same patient and making that available in an anonymous way while avoiding the risk of reverse identification that perhaps pseudonymization or tokenization might bring.
This is an excellent question. Thank you very much. It's got a really long answer, so I'll try and make it as short as I can. So at FITFILE, we've got what we call our anonymization protocol, which is configurable. So every time we sit with kind of a different customer, we will understand what the requirements are and what they absolutely need to get and what they would be happy having into a little bit of a more generalized way. So the protocol uses a variety of methods. It uses randomization techniques, it uses generalization techniques. But the important part to note is that it is dynamic. There's no one solution fit all here. So the protocol is dynamic and it attaches itself and treats data based on the data sets it had to deal with. So to give you a very unscientific example, if you've got a data set with pretty uniform data, 100,000 rows, the protocol has got a much easier job of identifying, the groupings, the combinations, and what it needs to do. If it's got a very small data set of, let's say, 100 rows, its job is a little bit harder because now everything is less in terms of numbers. So for those that understand, for example, k-anonymity, we're talking about lots of smaller groups. Or, for example, if you had people with a rare disease, the protocol has to do different things for that particular cohort. Now, the protocol ends up with a set of data that is anonymized. We test it against the risk of de-identification along the way after everything that we do to process the data. And if the protocol deems that the risk is very, very low, then it will present an answer, an anonymized answer. If not, it can give recommendations and say you might consider widening this requirement, or you might consider a big data set. I'm generalizing for effect here. And if even that's not enough, it can give you an answer that says, I can't give you detailed data, but I'll give you an aggregated answer. So I think the answer to the question, unfortunately, it's not black or white. It's a lot of kind of shades of gray, but the protocol is clever enough. It can work independently, and it will get to the point of giving you the best answer it can give you without compromising analytical utility as much as it can.
Thanks, Petros. All right, so got another question, Mike. I saw you had your hand raised, but you also dropped your kind of question into the comment box. So do you want to ask your question directly?
It's about 4 questions, but if time then you can pick which question you answer. Okay, so firstly, Kamal, thank you very much for the presentation. Very interested. Mike D'Ambrosio, I work for Sirius Health. I'm a vice president in our real world evidence group. So I kind of got looking at the data, and I was kind of curious on where you go next. So I think number 1 in the list of questions was around overlay of additional enriched data. So had there been a consideration, because you mentioned that earlier in the presentation, Kamal, around the actual true cost of care right? So can you get a deeper health resource utilization cost to look at those practical economic benefits or not, I guess, of, you know, the drug A versus drug B and that clinical benefit? That was the first question. The second, Petros, you kind of answered, but I'm going to dig a little deeper here, okay, as I always do, is the data. So structured versus unstructured. At the moment, it seems like you're taking predominantly structured data. The curiosity question from me, Petros, is whether or not there's potential further downstream to try and augment an unstructured data, maybe using like kind of machine learning, NLP, to get deeper insights. The third was really the safety. That was a really interesting one for me, Kamal. I looked at that safety slide that you sent, and I was thinking, right, well, you know, first of all, admission to A&E is probably a surrogate in itself of safety profile and durability of response. But how deep or how much deeper can you go on the safety to really try and extract benefit on a safety profile basis of drug A versus drug B? And then the final question, I promise it is whether or not you'd consider to use this data. Again, thinking about durability of response, could you kind of use that A&E data as a surrogate to say, right, uncontrolled patient, if we know they've switched, which you clearly have the switching data, you presented it on slide 1, could you consider, do we use that to make a decision point on further switching, or do we use that as a consideration step to potentially introduce the patient to a clinical trial for a new therapy? So that's the 4 questions. Pick whatever you like, or none, as the case may be.
While the team I'll start with question 1. Look, unless you do things in real time, to get a true cost is impossible, which is why the simplest model is a block contract in how we deliver services. Okay, because I don't think we have the resources for even our 1,000 biologic patients to work out the true cost. But there are lots of surrogate markers. So, you know, we've got the cost of drug. We can only offer these patients 2 clinic appointments at the moment. Okay, we can extrapolate how many emergency appointments we're giving based on the data we have. And then also we have the cost of an A&E visit. We've got surrogate markers we could use to see their true cost. So we can look at all of that. Now, this is real world evidence, real world data, sorry, not so extrapolate. Doing a comparison between drug A and drug B is not fair from this kind of data. We would have to have propensity scoring, firstly, analysis to see are the 2 populations comparable for other confounding variables.
Yeah,
so we can't do that. But, you know, I absolutely agree that if we could do that, then data like this, again, is so powerful, because then I can use this data to go, if one drug is showing better for our local population, which a clinical trial cannot tell you, and even real world evidence cannot tell you, because the real world evidence is multiple populations across still either a nation or a continent or multiple continents. You know, my primary aim is local treatment with local population to do the best for them. And if one drug is showing a better signal, then, you know, you can go to the companies to say, if you do something with your drug tariff, we can use your drug sooner. Okay. Or at the moment, one drug was massively overused because it's ambulatory delivered. But if that's harmful to the patient, we can also, you know, have discussions around that. The companies are making subcut preparations anyway, so this may be irrelevant in the future for these drugs. But, you know, there are ways of going around it. But at the moment, the sequencing of drugs is purely done on cost, because companies don't like doing head-to-heads because one will lose.
Yeah.
Okay. So, you know, that's question 1. I hope that's a fair answer. Question 2, I'm going to give to Petros, and I think it's for Petros.
Yeah, so this particular work, Mike, we used mostly structured data. FITFILE does have the capability for unstructured data, and it's just a case of working through the unstructured data, annotating it, and effectively what we do is we give it context. So the unstructured now becomes structured. Now, I'd love to say there are upfront easy ways of doing this. There isn't a perfect way of doing this, and every time it's different. But we do utilize machine learning where we can to make that process a lot faster. But there is a little bit of effort that clinicians have to put in, at least to start training those models.
Yeah, perfect. Thanks, Petros.
Question 3, Petros, is that for you?
Yeah. So
I think, go on, Petros. Yeah.
No, Gerrit, I'll follow you on that one.
I think this relates to the depth and breadth of data and information we want to extract for the study. So we had a very defined process that we wanted to follow for this particular project, and absolutely we can go very deep, very wide, and then we can incorporate unstructured data elements as well. There's an additional complexity there, as everyone knows, but certainly we can incorporate that to then get together more safety data signals and points, which are really important, and pull that together and get to a certain level of granularity. We started off with this, and we thought there was some already quite unique and interesting, and actually from Kamal's perspective and for his team and for the trust, significant cost finding results really, which they're going to take that on further and discuss with the ICS, for example.
Perfect, thank you.
So I'll take question 4. Can I just apologize? I still call the ICS the CCG. So in this talk where I've said CCG, I do mean the ICS. Okay, so look, cost, I'm not going to go back into now because that's for me to take forward. Equality in this data, that's a massive piece of work which we 100% will undertake. And if we do another session in a year, I will be happy to say what I have done with the equality data and how we have progressed it. But you've asked a very interesting question there. And, you know, research is actually probably the only reason I still keep working for the NHS, if I'm going to be honest, because that's the character I am. And I want to leave the service in a better position from research impact than I joined it. So, you know, that's one of my career goals. Now, we showed the obesity data, which actually has never been answered. The obesity question is there. Obesity is a pro-inflammatory question, but there is another drug company, the company have shown that not in these 2 drugs, where obese people tend not to respond as well to that drug. And this is an area of research which now needs a proper research question and proper research project to take forward. And, you know, myself and Gubs are already in the process of speaking with someone in London who is more of an obesity expert than I am, with an interest in IBD, to say, you know, what do we do with this and how do we take this forward? Now, I just thought I would put that in from the data we have. Now, with respect to question 4, if we can develop a dashboard which shows in real time this CRP is abnormal, because one of the real problems we have in the NHS is we're always playing catch up. So when a CRP gets to me, it's 2-3 weeks later, which is still pretty good and within the framework we have, but it's not real time. If we have a dashboard to show this person is flaring, then we can impact on A&E by getting to that patient quicker. We actually run at St. George's one of the biggest interventional clinical trial programs for IBD in the country. So we're running all of the new molecules. But again, you see challenges from this data where it is very difficult to put somebody over the age of 70 in a clinical trial.
Of course, inclusion, exclusion, yeah.
Yeah, not even exclusion. For somebody to come to hospital twice a week, which is what, every 2 weeks, which is what a clinical trial protocol requires, is not so easy for the elderly population. It's not appreciated. Yeah. So, you know, again, what we need is a breakdown of, is it the younger cohort who are struggling? Is it the elderly cohort who are struggling? You're absolutely right. These are the last line drugs we have on the NHS. So if it is the younger cohorts, then we should be putting them into clinical trials sooner. If it's an elderly cohort, then that's not as easy to treat. Yep. And we need different mechanisms and we need different processes to address that. So I do agree that there is a lot of surrogate markers here that we have active disease, which I have to be honest, as a department, we haven't appreciated, because our admission to hospital for IBD over the last 7 years has gone down by 70%. Wow. But that doesn't mean the admission to the front door or to admissions to GP has changed. And this is where, you know, the silos of data becomes so important, because all I see is on my ward round, me looking frustrated saying I'm an IBD doctor. And I was on call last week and we had 1 IBD patient in hospital the whole week, which used to be 7 or 8 when I started as a consultant 6-7 years ago. Okay, so the data, what I see is that these people are no longer in front of me, but that doesn't necessarily mean they're not struggling.
Yeah. Perfect. Thank you, Kamal. That's really, really helpful.
Okay.
All right. So I think what that has very neatly done is segued us into what we'll come on to in just a moment. I'm mindful of time, which will basically explain what the next steps are on this program and the different areas that they'll be investigating and interrogating. But before we get there, I just wanted to come to Lucy, who had a question. Lucy, did you want to ask it.
Thanks, Jessica. Thank you. Hello, FITFILE crew. So I'm Lucy Burgess. I'm from Helix Data Innovation. We are a healthcare strategy consultancy. So I wanted to know a little bit about how repeatable this is within healthcare organisations, because it sounds like this was quite a long project for lots of good reasons. I'm sure the information governance, I'm sure, being one of them. But if you're going to do this again, how much handcrafting is needed? Do you have to take a project approach from scratch every time, or is this something that you could roll out to other conditions, aside from IBD across St George's? And how easily can you do that? Thank you.
Okay, I can start that one, and Gertrude, feel free to kind of jump in. So the answer is it's very easy in St George's now. We've gone through, if you like, the pain of governance. We've gone through the tech integration. The platform is live, and it's a very easy thing to say, I'm going to expose the platform to a new data source now, so it can go and grab even more data. So when we have things like multi-sites within the same trust and we've got the platform in, then we get and extend it to everything else. Now, that makes it a hell of a lot easier and much less burden for the trust to deal with. But it's also, I think, worthwhile mentioning that the more of these we do, the easier the process it becomes to deploy to a new place. So now we have every possible answer to every possible TPIA question, and these things move a hell of a lot faster. If I remember from the first project we've done to this one, we've reduced the time by something in the region of 50 or 60%, and we keep getting better. So once we're in, it's very easy. I won't say instant, but it's very easy to include in the scope of more data sources, and the new ones that we do, we can get there a lot faster. So one last thing for the visualization part. Although this was very particular and very specific, we do have ways where we can accelerate common use cases. So if we're talking about, for example, feasibility and recruitment, or if we talk about particular TAs, we have ways where we can accelerate the end result. So what you see and what you feel. But we mustn't forget that because we have privacy controls built in, it's not a real-time process, because there have to be approvals. People have to be confident and happy with sharing even the anonymized data. So in some cases, you have to have control when somebody says, I'm happy to release this data, click here. So it's near time, and the results come to you in the fashion that you selected.
I think just to add to that, in terms of the two products we have, one is FITFILE that does the anonymization, which is critically important for a project like this. And then to the point made earlier, if a few patients are flagged and really need to be identified in some way, then Kamal and team can rerun that process. FITFILE doesn't have any view of that, and full privacy is maintained, but Kamal and team can rerun that process to identify the few patients that they need to get in touch with and contact, and optimize their care. Him being the consultant and clinician looking after those patients then has that ability, and we have the technology to be able to make that happen.
Fantastic, thank you. So I am very, very mindful of time, and I think we've had some brilliant questions there. So thank you to everyone who has stuck their questions in the question box, raised their hands. Would Petros, I think you are driving the slides. Do you want to just show? Yeah, Petros has got his hand up. Come back there.
I was going to say, if in any case, some of the answers on anonymization I know are not detailed enough, we don't have enough time, we're more than happy to do an individual session and give you a lot more detail on how we do it, what the benefits are, how we certify in a way that the risk is absolutely minimal, etc.
Perfect. Well, thank you so much. So Victoria from Analyst X and the Population Health Data and Analytics Centre of Excellence has also just popped a link in there to some similar events. But I think given that we are now at the top of the hour, I wanted to thank everyone for joining us today. I have thoroughly enjoyed this discussion. Thank you, of course, to our panelists for sharing your experiences. I'm sure there is so much more that we could have covered, and we really have barely scratched the surface. So if anyone has any other questions, I'd encourage you to reach out to Petros, Gurpreet, Kamal. They will be very happy to answer any queries, questions that you may have. but I do hope that this has been useful to you, and we hope to see you all again for another session like this very soon. Panel, is there anything else that you'd like to add before we wrap up?
Just one small thing. If you ever need a demo of this, if you want to see it live, see how it works, what it does, we're more than happy to oblige.
Yeah, I just want to say we have loved working with Kamal and his team, and we think this is just the beginning. Really, there's so much that we can do with the technology that we've developed, and really, really improve the use of biologics, treatments, diagnostics, and most importantly, to keep striving to improve the outcomes for our patients. So we're really motivated by that.
Fantastic. Thank you so much. Thank you once again, Kamal, Petros, and Gurpreet. Take care, everybody. Enjoy the rest of your days.
Pleasure. Thank you, Jessica.
Thank
Bye.
you.
Thank you, Jessica. Bye.